couple of housekeeping items, so I'm going to just jump into those right now, Sarah. Before we get started, I've got a couple of poll questions I would love people to answer. So if you can pull up the poll there, hopefully you see the poll on your screen. Sarah, can you launch that? I can't see it, but hopefully you guys can see it. If you can't, let us know in the chat. So let us know what percentage of patient records in your organizations do you believe are duplicates? And also, we'd love to know what the most difficult challenges that you're experiencing right now with patient matching. We have a couple of different options there for you. We're just curious about what's going on in your neck of the woods. So first question, what percentage do you think are duplicates in your organization? And second question is, what are the biggest challenges you're experiencing right now with patient matching? And this will give us a little bit of a sense of where folks are at right now. If you're not sure, just hazard a guess. Just to give us some background and things to think on during the conference today, the session today. All right, we'll give folks just a moment to do that. Okay, can we get going with the slides, Sarah, or do we need to complete the poll first? All right, great. Okay, and then Sarah, if you could put the videos up so we can show all of our speakers here, that would be great. Ooh, we just see your background, Sarah. We can just see your beautiful Zoom background. There we go. Okay, great. And let's pull the slides up again if we could, Sarah. It is a lovely Zoom background, though, I do have to tell you. Okay, so great. So let's talk about a couple of housekeeping items. If we can go to that first slide. All right, so everybody's muted right now. And we do want to hear from you. We'd love to hear your questions throughout the session today. There's a Q&A box in the bottom of your screen right there. If you click on that, we would like for you to enter your questions in there. Please don't enter them in the chat box, put them in that Q&A box right there. And we're doing something called upvoting. So you don't need to repeat a question. If you see a question in the Q&A box that somebody else has asked that you would like to see answered, go ahead and put a thumbs up next to that question, and we would that means that that question will get elevated and it's most likely to be answered today. So do that in the Q&A box below. We'll get to as many questions as we can. Next slide. Okay, for the agenda today. So I'm Jen Kovach-Bordnick, the CEO of the Ehealth Initiative, and welcome. I'm your host today and moderating a really incredible panel, a great group of folks here today. We're delighted to have with us Molly Murray, who's the Officer of Health Information Technology from Pew Charitable Trusts. Most of you may be familiar, they've done a lot of research and have a fantastic survey on patient matching that they're going to share with us today, and some really interesting results that'll help kick us off here. Then delighted that we've got Carmen Smiley here, who's the IT specialist with the Office of National Coordinator of Health IT, the famous ONC. Delighted to have Carmen here today, who's really involved in the project that we're going to be talking about today. And Dan Sedan, who's the CTO of NextGate, the Chief Technology Officer. Great insights to offer for the panel today on patient matching and what's working and what's not, and how to get this going in your organization. And then we will wrap up with Q&A and a wonderful panel discussion. So we've got a full, wonderful session set up for you today. Next slide. For those of you who are not familiar with the Ehealth Initiative and Foundation, we are a group of executives from across the spectrum of healthcare. If you don't see your organization's logo up there, that means that you're not currently involved in our work, and we would love to have you involved in our work. So please send me a note through the chat box, and we will figure out how we can get your organization involved in our initiatives. Next slide. So the Ehealth Initiative, we've been around, this is our 20-year anniversary. We do education, advocacy, and thought leadership on how to use innovation and data to improve healthcare. Next slide. currently we're working on 4 critical issue areas, and my guess is that you were involved in one of these areas if you were on the call today. We're doing a lot of work around consumer privacy for health data. We have a grant from the Robert Wood Johnson Foundation. We are trying to determine what's the best and the safest way to use consumer health data in apps and all sorts of healthcare systems that fall outside the scope of HIPAA. This is a great project and a great way to get involved. We're also doing a bunch of sessions and a lot of work, executive roundtables, webinars on virtual care. This is the new paradigm for healthcare. Another really critical area we've been doing work on: social determinants of health, artificial intelligence, analytics. Patient matching today certainly falls under that category as well. And then finally, COVID-19, best practices and education. A lot of work happening in these 4 areas this year. And again, would love to have you involved in our work. So feel free to send me a chat there if you're interested in getting involved. Next slide. This is just a sampling of some of the recent programs that we've had. Because we're a nonprofit, all of our research and educational programs are available online to the general public as part of our mission. So I encourage you to go and download some of these programs if you've missed them, or forward them on to colleagues to share. You can get slide sets, you can watch the recordings, whatever we can do to help you. We're really interested in making sure that this information is disseminated broadly. Next slide. And we've got a lot of publications that have come out in the last 12 months, a number of them around COVID-19, social determinants of health, telehealth, policies related to COVID-19, a lot of work around what payers and providers are doing, a lot of work around Native Americans and tribal communities that are dealing with COVID-19 right now and how they're using virtual care to reach out to people. Really interesting work, and I encourage you to reach out and pull those down and take a look. Next slide. And we've got a lot of great sessions coming up. The exciting vaccine passports, which has been in the news a lot lately, and we've got a really great session on this next week, April 6th. So I encourage you to join us for that. We're also going to be talking about COVID-19 and lessons learned for value-based care on the 14th. And the 22nd, we're going to be talking about preparing healthcare data exchanges for consumer health initiatives. A lot of interesting work. Again, I want to encourage you to join us for these programs free of charge. Next slide. And a big thank you to Don and NextGate for sponsoring and underwriting this program today. As I mentioned, we're a small nonprofit. We wouldn't be able to do all the educational programs that we do, generate reports, share all of these great best practices without the gracious, wonderful, generous support of groups like NextGate. So I do want to thank them today for their support. Next slide. And as I mentioned, we've got a great panel and a great group with us here today. We're going to kick it off with Molly Murray from Pew. So Molly, I'm going to turn it over to you now.
Excellent. Well, thank you so much. I appreciate the introduction. My name is Molly Murray. I'm an officer on the Health Information Technology Project at Pew. And for those who might not be familiar with Pew, the Pew Charitable Trust is a public policy and research nonprofit. We do work across the gambit. My favorite description is from everything in pensions to penguins, but that includes several areas across healthcare. And so the Health Information Technology Project is in about its 3rd year, and we've been doing work and research related to interoperability with a focus in patient matching. And so we're very excited to share some of our research with you and to hear from the rest of the panel. You can move to the next slide. And just like the poll asked at the beginning, one of those questions was, what do you think your current rate of patient matching within your organization is today? And so, in fact, in most organizations, 1 in 5 patient records are not accurately matched within that same system. And across facilities and across providers, whenever there's a transfer of care, up to half of patient records are not accurately matched. So this is obviously a big problem. It's been a challenge pre-COVID, but certainly the pandemic has highlighted some additional challenges as we're relying more on technology and remote solutions like telehealth to make sure that our providers have access to us and to our records. So patient matching certainly remains a very important aspect of ensuring that we're getting the right care at the right time, regardless of the provider or the system. And go to the next slide, please. And so, of course, with all of these challenges, there are implications. There are costs both to the hospital and to the health system as a whole. And on that slide there, you can see that at some organizations, it costs over $90 with patient mismatched records, and that to fix records that were inaccurately matched, the Mayo Clinic found it could cost up to $1,200. And so those are some big dollar signs. And then also, even more importantly, those mistakes can harm patients. And so in a survey from a few years ago, 1 in 5 hospital CIOs mentioned that there had been a case of patient harm due to a mismatch of records. And I think for those of us who might have unfortunately had this experience as a patient, we know that there can be duplicate tests, wrong medications, inaccurate risk assessments. So the potentials for harm are high and the costs are high too. So we're looking for solutions that can bring us some change in the short term. Next slide, please. And so to have a good sense of those solutions, it's helpful to understand the root and some of those common problems. So that first one, typos, we are all guilty of that one. So data entry errors. I often spell my own name wrong frequently when I'm typing too quickly. So in systems, that can certainly be a challenge if it gets saved that way. Changes in patient information like moving or name changes or new phone numbers, that certainly happens a fair amount. I know I've moved a bit over the last decade, and updating my address with my provider tends to be lower on my list than of other moving checklist items. So that can happen a lot, and that can cause old information to stay within systems. Formatting is another challenge. So in a past life, I worked with a few different EHRs, and I know that there are some differences on, do they take characters in last names like dashes or apostrophes? Is there a character limit for length of certain, fields like last name or street name, things like that? And so without having the standardized formatting across systems, so you're allowed to enter information in different ways, and then when you're exchanging it, it may be different between systems. And then missing data is also a challenge. So, and as we've seen in COVID, I'm sure many of you have seen the articles about, missing contact information or missing race and ethnicity information. And so those gaps in data can also make it more challenging to be able to accurately match records across systems. Next slide, please. So we've talked a lot about problems. You've all probably experienced and are familiar about the problems. So what can we do? A near-term opportunity for improvement is relying on standards, and relying on standards can help ensure that data is consistent across systems and more reliable to use in matching. Past research has found that standardizing an important data element, address, to an existing standard, and this research that we did looked at the United States Postal Service address standard, that alone increased matching rates up to 3%. Now, 3% might sound like a small percent. I wouldn't want to get that score on a test in school. But in this scenario, it can actually result in tens of thousands of additional correct record linkages per day. And so an organization that has a match rate, say, of 85% could see its unlinked records reduced by 20% with standardization of address alone. So there are a few reasons, why this isn't happening in practice everywhere. The USPS address standard does have some current terms and conditions that restrict its free access or free use. So it's not available free of charge for healthcare use. And additionally, as Carmen will cover, the USPS standard still allows for modicum of variation within it. So the UNC is working to create a more specified standard for address, but I will let Carmen get into the exciting details of that work. But it is a great step towards standardizing addresses across the healthcare industry, which can really help improve match rates. Next slide. So in light of the COVID pandemic, I know that's a use case obviously that we are all in the midst of. Patient matching becomes even more important. And like I said earlier, we've probably all seen those news stories that are reporting on lab reports that are missing patient contact information or vaccine data that's missing race and ethnicity. And missing data makes matching harder, especially if patients are, say, getting vaccine dose 1 and dose 2 in different places. And so that missing data certainly was an issue pre-COVID, but the volume and additional places of care and additional flows of data have definitely exacerbated that problem. So complete data following standards can be a pathway to help ensure that we've got the correct info on the correct patient, both in the next few months and also in whatever future pandemic we may have. Next slide. So speaking of address standardization, some of the immunization registries across the country have already begun taking steps to standardize data and even started doing this before the pandemic. Since those registries get data from so many different sources on the same patient, matching is really important to ensure that we've got complete vaccination histories for individuals. And so a few years ago, ARA actually saw the research that the USPS address standard could increase patient matching rates. And so about half of the immunization registries implemented a third-party tool to standardize addresses in their system to the USPS standard. So they worked with the ARA Association on implementation, and with it, they found both increased rates in patient matching as well as in mail deliverability. So there are some additional pros of implementing that standard. And we hope that Project USA, which Carmen again will talk about, can bring some similar improvements across the health IT system. Next slide. And this is my last one, I promise. So, and to connect all this back to the patient and patient research. So in 2017, Pew conducted some focus groups to better understand patient perspectives on matching and what it was that they hoped to achieve. Back in 2017, patients were anxious for a solution to improve patient matching and supported the federal government taking some action on that. We followed up from the focus groups with a more in-depth survey last June of 2020. Which now seems like 2 years ago instead of 1, but the result of that showed even more support of the federal government creating national standards to improve patient matching. And so over 70% of adults, and that represented a majority of adults across political party affiliation as well, support the federal government setting standards to improve patient matching, which is excellent news because that is exactly what ONC is working on with an initiative that Carmen will talk about next. So thanks very much.
Great. Thank you so much, Molly. And we're going to switch over to Carmen now, who's going to give us an overview of Project USA. I think we can get rid of the slides. And 1A, can we spotlight Carmen here or Sarah? Great. Thank you. All right. Take it away.
Thank you. And thank you, Molly. That was perfect. That was a perfect setup to the discussion because Pew Charitable Trust, actually the research that they led in partnership with Dr. Sean Granis at Regent Street, actually inspired sort of a renewed discussions around standardization of data, especially around addresses. And then ONC received comment on the 21st Century Cures proposed rule. There was a patient matching request for information where a number of commenters recommended that we consider Publication 28 to be adopted within the U.S. Core Data for Interoperability Standard, or USCDI. And after incredible analysis and deliberation, we decided not to adopt Publication 28 as a required standard for the address data elements underneath the patient demographics data class in USCDI, but we acknowledge that standardization has great value. And just as Molly also had alluded, that these small victories can actually add up and can be quite impactful if you're really considering the number of data records that are exchanged on a daily basis. So kudos to Pew, of course, for inspiring this. Kudos to everybody who commented on that patient matching RFI and to all of our rules. We are listening. We appreciate all of your feedback. I forgot to introduce myself. My name is Carmen Smiley. I'm an IT specialist in the Standards Division in the Office of Technology at ONC, and I'm ONC's subject matter expert in patient matching. And I'm excited to be here. Thank you, Jen. Thank you, EHI and NextGate for making this discussion possible. The approach that we're taking, it's pronounced Project USA, not Project USAT. I know there's a little bit of confusion there. I think it was meant to be a sort of a play on the at and A at the same time. This is Steve Posnack. But we typically just describe it as Project USA, and we intended to, in the first phase of the project, was actually primarily focusing on US domestic addresses and military addresses. And our goal is to issue a unified cross-standards development organization, healthcare industry-wide specification to represent patient address, not provider address or facility address or any other addresses. We're starting with patient address. And this is the first specification, to my knowledge, that is, or standard that is developed specifically for patient addresses with patient matching in mind. And so, many people on the line, I'm sure, are highly involved with the development of standards across the industry. But in the standards development work groups that I have been in so far, we will talk about patient matching, but in the technical work group discussions that we have with many of these incredibly smart technical work group people that are working on Project USA, like Dan, we really cover the gamut of patient matching issues, and we discover all possibilities and any other consequences of our decisions as we go through the development of the specification. We started with a foundation of Publication 28, of course, because nobody knows addresses like USPS. But we're building it and sort of further constraining it to reduce the variation that Molly referred to, because for the purposes of patient matching, you actually want to reduce variation, provide that sort of uniformity of application for standards to really receive the greatest return on the investment for that standard, and really help to facilitate interoperability across systems, including for patient matching. And so we're collaborating with standards development organizations, we're collaborating with federal agencies, we are collaborating with lots of health IT developers and a wide array of other stakeholders across the industry. We really want to be able to gain industry consensus for a number of administrative and clinical transactions where the specification could be applied. We'd like to build excitement and adoption from the ground up. And so everybody that's on this call, I hope that you will check out, I'll place the URL in the chat in just a moment. I hope that you'll check out our site and contact us and join us as a project partner, just to stay apprised of the developments of the project over time, or to get involved in the technical work group, begin to discuss the implications of standardization of patient address data and patient data in general, and the value that it could bring to patient matching and record linkage within your organization and within the organizations that you partner with. What lies ahead is through the rest of, we're in April now. April and May, we will continue to develop the specification. Our deadline is June of 2021 for version 1 of the specification. In July, HL7, X12, and NCPDP have all graciously agreed to release the specification for comment among their members. This is an out of cycle comment period. There will be, I believe, a 30-day period for each of the SDOs. HL7 has also offered to post it on a site where it is not, the access and review of the specification won't be limited to those who are HL7 members. So keep an eye out for any announcements for your opportunity to provide comment and any additional feedback. Those comments will feed back into really create a feedback loop between all of the SDOs and ONC that will further inform future versions of the specification. And future versions are likely to include, of course, they're all based on the comment as well, but we're seeing great value and great demand for things like geolocation data to supplement patient address data that could help for a number of ways, especially public health emergencies. And there are other standards that go beyond the borders of the United States, especially those countries that are contiguously located to the United States, where patients could cross borders on a regular basis, yet still receive care. And so that is another area that we hope to focus on in the near future. We're also partnering, and I'm excited to let you guys know about an additional partnership that has blossomed out of this effort is between ONC and AHIMA. We're hoping to develop a companion guide that would supplement the specification that is focused on the health information professionals who are responsible for capturing this data and for maintaining this data over time. And anybody who works in patient matching will tell you that if we could just improve the quality of the data at capture, we wouldn't have to work quite as hard down the road to be able to accommodate any variations or poor other versions of poor data quality in that data for matching. And so we want to be able to cover the entire life cycle of that patient address data. I hope that was helpful.
Great, thank you. And it sounds like the AHIMA guide is going to be a wonderful idea.
Thanks.
Great partnership. All right, now we're going to turn it over to Dan Sedan, who is the Sedan, excuse me.
I'm a Sedan. Go ahead.
No, Sedan, who's a CTO. And Dan's got some really great perspectives as a data recipient about some of the challenges as well.
Thanks, Jen. And I'll try to be as cogent and poised as Molly and Carmen that did an introduction. So yeah, my name is Daniel Sedone, and I'm the Chief Technology Officer of NextGate. And NextGate, unlike Pew, we have a relatively laser focus. And Molly, I did look up the Pew report on penguins. It's pretty astonishing. It's from 2014, so I think it's time for an update. But we focus primarily on patient identity, but we also focus on the identity of practitioners of care, where there's kind of a similar issue of fragmented data, incomplete records, the discrepancies due to some of the things that Molly showed in some of those slides. But really, we've been focused in this space for a good 20 years. And really, when I think about the work that Pew and ONC have been doing, I would say that had we started off 20 years ago and we had a guide like Project USA that I could hand over to the development team and say, hey, look, when you think about address data within our master patient index, these are the kinds of things you should think about, because it's a very complete guide. The draft that I looked at just the other day, and it's still a work in progress, but it's already close to 100 pages long. There's a lot of material there. And it's surprising just how much nuance there is in how do you deal with addresses in a way that maximizes their utility to determine who the individual is, and that's a very different ballgame than trying to package flowers to your mother or something like that. That's a different game. That's a equally difficult. That's where we start to talk about some of those USPS standards, which are really all about delivery of packages. When it comes or letters, when it comes to patient identity, in some ways that specificity can be too much, really, or unneeded, unnecessary for the purposes of identifying the individual. And there's all sorts of. If you ask yourself the question, well, why another standard, and how is this really different than other standards around address information? There's a lot of address data that's captured in healthcare settings that just for practical reasons, people are entering bits of information that describe the patient rather than describe the patient's address. They'll put metadata in there. They may put an address that represents the hospital address as opposed to the patient's address. There's a lot of things that happen practically that have to be addressed, and that's captured in a lot of this Project USA specification. What do you do? I mean, Carmen, I think we had an entire afternoon just talking about what do we do if the patient's address is unknown, right? And should the unknown show up on the address line? Should it show up also on the postal code? Should it show up everywhere? Should we not show it at all because it's confusing people and all of that? And so there's a lot of really great people that are discussing this, a lot smarter than me, thank goodness. I'm happy if I make 2 or 3 comments that at least seem to move the needle somewhere on a conversation. But there's a lot of people there that are really have a very good handle on it. So I think this is it's not just an exercise. This is really something that as I said, if you are in in a place where you have to deal with address information within your systems, and you're needing a starting point to say, okay, let me think about all the issues that I'm going to have to deal with, then that's your starting point right there. It's as good a starting point as I could think of. And I really hope that as people start to read through it and they start to use it, that we'll see at least a lot of those ideas appear, and we'll start to see some of the matching improve. And the reason that the address information is so important, is because, and I guess trying to go back to the way Jen described this section as the recipient of data, we are the recipient of demographic records, which include name and the birth date and all sorts of stuff, but among which is the address. And for us, almost a third of the identity, if you were to kind of score it the way that we do and come out with a likelihood, about a third of the identity, comes from the address, and especially these days where things like the social security numbers is either not transmitted at all or only very small parts of it. Really, in order to figure out who a person is these days, you can rely on the fact that you'll get a name and a birth date and a gender. But then what else do you really get, right? You'll get hopefully an address. If not that, then you'll get a phone number, and so we start to rely more and more on these sorts of data elements, and that's why getting as much value as you can out of them is really important, and not placing too much value in them. For example, the unknown address, the emergency, hospital address or whatever. Knowing when not to use that information is just as important, because the costs that Molly pointed out there for dealing with records that should have been linked or records that should not have been linked or whatever, it is very costly. Now, going back to just make a few more points, going back to the notion of things like the USPS and geocoding and things of that sort, we have in the last, I think it's already now 4 or 5 years, we have introduced to our own product the capability of geocoding, and we do that with our partnership through Locate, which is an organization that specializes in addresses. Trust me, when it comes to dealing with addresses, you don't want to write your own software for this. This is really something that there's so many different countries with so many different formats, and as Carmen said, we've really been kind of focused mainly in the US, but really, we have to be able to deal broader, with the rest of the world. And so this is something that we have worked with Locate, and so address information, in addition to the matching of patient records, is really important from an analytics perspective, from billing perspective, being able to actually send information to a patient, for things like determining the closest point of care of a patient to a facility. So that's when you start to see kind of the importance more on the kind of USPS style, which is equally important, I would say. It's not what the focus is of Project USA, but it is something that is of importance, and it's important to kind of consider it as a separate thing. You don't necessarily need that level of address matching in order to have a lot of the benefits that Molly and Carmen were outlining. So yeah, I mean, I guess my only other comment, as I say, I'm not as cogent as these other two, so I may be a little bit meandering, but we are a recipient of the data, and I kind of look at it like recycling. We tend to throw a bunch of stuff into a bucket. Somebody comes once a week and takes it, and you hope for the best. You kind of hope, oh, I did my part, and unfortunately, the truth is like only a fraction of the stuff that we recycle actually ends up being used, and it's a kind of similar thing when it comes to as a recipient of patient data. People throw all sorts of things at us, and they hope that at the end of the day that we'll make something out of value from it, right? So what we provide that's of value out of all of that is essentially a crosswalk of identifiers that acts as the basis of a lot of the integration, with these best of breed systems that exist out there, but to the degree, just like with the recycling, you should separate your glass, you put your plastics here, or the paper, or whatever. This is kind of like that pre-sorting, I would say, that has to happen, so that we can do more with that, with what we received. And at the end of the day, we can create a very good product out of that data. The crosswalk is one of them. But just like these efforts at recycling, you have to ask yourself, why are people throwing away so much stuff? And when we look, and maybe we'll talk more towards the end of the discussion, if we look towards the future of all of this, we understand that all of these efforts are never going to get us to 100%, right? So long as we're leveraging string matching and whatever for addresses and names and all of that, it's never going to be 100%. It's part of the reason that we at NextGate are looking at decentralized identity as an approach of taking and converting all that information into credentials that could then be presented at points of care. And that's a whole other discussion. Actually, next week's thing that you guys are talking about with the vaccination certificate or passport, that is kind of along those lines. There are different approaches that have been proposed, but the idea of a reusable, portable credential is important, and certainly one of the things that will form the basis of those credentials of the future is good address information, good set of demographics. So the effort that is taken today in today's world of patient matching and all of that is not wasted effort. That actually acts as the starting point, for hopefully a new future where we're not trying to take any guesses as to who a person is, but we actually use credentials that are pretty much deterministic in their capabilities. So I'll stop at that and turn it back to you, Jen.
Thank you so much. And Dan, I'm hoping you'll break out into song soon. I see the piano and drum set behind you.
Oh yeah, let's do that with my kids.
Yeah, great, but really great perspectives. And I'd love to revisit some of the challenges as well. I know we asked at the beginning of the session here today. So Sarah, could we bring up the poll here and see what our audience is saying some of the biggest challenges are here? So the percentage, was between 6 and 10 here. So a little bit lower than what Molly found in her national survey, which was 18%, I think was the national average of duplicates in the Pew survey. So we're ranging between 6 and 10 here. But let's go to the next question there, Sarah, if we could. Better way to go to the next question. The biggest challenges. Can we page down to the next question? Okay, not sure if it's going to let us do this.
Sorry, Miss Jen, it is not letting me do that.
That's okay. All right, let's just pull up everybody's videos here, and so we can see everybody, and we will jump into the panel discussion. And we've got a lot of great questions here as well. So if we could, I want to remind folks to please put your questions in the Q&A box there. We were also getting a lot of questions about whether or not the slides are available. And the slides will be available at ehidc.org. We're also going to send out a link to everybody, an email later this afternoon or tomorrow. I know Carmen's put a number of links in the chat box here to Project USA documents, and for more information, we will send those all out again to everybody, these ONC links, because I know there's a lot of interest in that, Carmen. Carmen, can you talk a little bit about how the partners are working in this effort? What does the partner do and how do you engage with them? So I know that you've got a lot of interest here from the audience in getting involved here.
Yes, thanks so much for asking. And actually, and all of you are welcome to become project partners. And the project partners, I realize everybody's plate is incredibly full right now, but we would love it if you could just attend one meeting a month where the project partners all come together. You receive updates on our progress for the development of the specification. You hear about other related projects and other efforts that are surrounding and that are intended to support adoption in conformance to the specification. And so please reach out to us. I added the link to our Confluence site, and my contact email is there. Just send me an email. I'm happy to forward you the invites. An additional opportunity would, of course, to join the technical work group. These are some that, like Dan had explained, very, very smart people. They're typically pretty technical discussions. And so just join as you're able. Project partners, we're hoping just to help to encourage excitement around it. We want to create awareness around it. We would like for it to be sort of adopted through diffusion across the industry, because we would like for everybody to understand it's there, see its value, and really kind of use the old school social networks where you would tell a friend to tell a friend to tell a friend. Do you remember those? That sort of approach, and to really just to increase adoption. And we want to hear from you. We want to hear your comments on the drafts and any concerns that you have. And we certainly don't want to leave anybody out.
Molly, could you talk a little bit about, from the survey, some of the different challenges that people were facing around the country? Just speak to that a little bit.
Sure. So that survey was actually a report that was done by another organization, and I'm happy to send out the link to that. The survey that we did last year in 2020 talked about how patients most wanted to receive their health data, and then also what they felt like were the priorities in terms of improving patient matching. So, like I mentioned, patients were overwhelmingly supportive of the federal government setting standards to enhance patient matching. That was, I think, 74% of respondents supported that. We also asked some additional questions on patient perspective in terms of longer term solutions in addition to using standards in the near term. So, what are their feelings on the use of biometrics, on the use of smartphone applications, on having a unique identifier in the form of a number or in a card. And so we've got an issue brief actually that will be published in the next few weeks that goes into great detail on all of the thoughts that we collected over the course of that survey that I'll be happy to share with EHI, and you could send that out to all of the attendees as well. So patients are ready for a change here. We had a pretty split mix in terms of their first solution, though the use of biometrics was quite popular. So something to consider and think about over the long term in terms of other potential ways to improve patient matching.
Dan, can you talk a little bit about how kind of a national standard would help in terms of data collection, what the challenge is right now, and how you foresee things changing if we are able to get to this?
Yeah, I mean, generally speaking, that I would say, national efforts can have a big effect. I mean, we saw that over the last 4 or 5 months as the federal government has taken over more aspects of the vaccine rollout. There's been, I think, more coordinated response than just allowing the states to do whatever they're going to do. And the data collection is really something that ideally should be based on standards that are national. When it comes to standards that affect patient matching, we have for a very long time been proponents that the IHE standards are really ideal for ensuring that organizations are communicating data about individuals consistently. So addresses just one piece of it. There's a lot of other things having to do with their identifiers, such as their medical record numbers and indicating the status of those identifiers and the demographics, your name and your prior name, and a lot of other things that there have been many standards for years. And unfortunately, the adoption of those standards has been somewhat weak. And I think that it's important for organizations to understand that and try to push the vendor community towards using those standards. Because the more incentivized the industry is in attending these sorts of testing events, the interoperability testing events based on standards, and the more incentivized they are in improving their adherence to the standards, then the better it is for the industry in general. Because right now, really, it's still very kind of chaotic, how people are handling most of this stuff. And again, as the recipient of this stuff, it is we've had to put in a lot of sophistication in our application in order to deal with it, because of the fact that it's just kind of coming in with very few controls in place.
So, I mean, Dan, assuming we're able to get to this, and Carmen, I'm interested in your thoughts on this as well. What is implementation going to look like if we do get to this for providers versus vendors? What are the responsibilities of each group?
So the responsibilities of each group, well, I would believe the health IT developers would adopt the standard once it is named. And after the finalization of the specification, it is open for adoption for consideration by ONC for adoption within US CDI. But at the same time, now I'm referring to the specification. But because we're working with all of the other standards development organizations, after they release the specification for comment, then we'll work together to integrate the specification into existing standards, or rather future versions of existing standards already in play. Just to be able to support wider, much wider adoption, and hopefully to ease some of that adoption on developers. And for providers, that's really most of our work with AHIMA is focused on sort of the burden that they have in collecting patient data accurately. And mostly for, of course, health information professionals, the front office staff and the scheduling staff and so forth. So we're hoping to provide some guidance to them and the reasoning why data quality is so important. I have been that person at a front desk of a health system, and with, it was a pediatric health system. And so there were always screaming babies and it was very difficult, and things would move very, very, very quickly. But many of the decisions that were made, or the systems that we must have worked in, it was never explained to us why certain things were important. So I think that training, that engagement, and just everybody that affects sort of the data quality and is affected by it.
Yeah. Dan, what about kind of from the vendor perspective? What do you think implementation will be like?
Well, I mean, for us, I would simply take that specification and give it to the R&D group and say, make sure it's all of these different use cases. I think from the, for us as an organization, there's the software piece, clearly, and but there's also the implementation and services team, and it's a big integration effort at the end of the day, an EMPI, because you're effectively setting up a communication between all these different disparate systems, and you're trying to funnel it into a single application. And we do get questions along the way from organizations in terms of, how should we handle it if we have this type of an address that we know is invalid? Should we filter it at the source? Are you guys going to take care of it and all of that? And I think that being able to provide a guide like this to our customers would also be helpful, to say that we have an expectation that the data is going to be presented to us in this way. At the same time, like I said, on our side of it, we're going to kind of assume that it's going to be a little bit of a Wild West situation, that people aren't going to necessarily get it into that form, but the different kind of stories that are painted in that specification are very useful for our team to say, okay, assuming that the address did not come in this form, but there is this kind of possibility of what the address might look like, how will our software deal with it? So I see it both from a the technology software perspective, but also the kind of communication that we have when we implement, and the things that our services team should push.
Great. Well, we've got a lot of questions here, so I'm going to jump in here, and I do want to also encourage audience members. Carmen and Molly have answered some questions already, so if you click on that Q&A box and go on the answered, make sure you don't miss those. Lots of information for you there. So one of the questions we've got here, a lot of people want to know, Carmen, are you trying to establish a different field structure or constraints on existing fields used to describe addresses? Can you talk about that a little bit?
Sure. We definitely don't want to create a whole new field structure. We're trying to accommodate the standards that are already in place and the applications that are already in place. And so, and as Molly had described, several people, immunization registries, including in many systems across the country, are already applying some version or some artisanal application of Publication 28 to address standardization. They're just all doing it differently. So that's why we started with Publication 28, and also because of the incredible knowledge that USPS brings to the collaboration. They're also actively involved in the technical work group.
Great. And we have a COVID-related question here, which I knew we would get, obviously around vaccines here. So are there solutions that would apply to pharmacies, related to the matching of vaccination records, adding that possibly to these cards or vaccination records? I'm just curious what your thoughts are about that. Molly or Carmen, if you want to jump in there.
Sure. I can take a start. So the ARA, which is the Association of Immunization Registries, they've worked with connecting pharmacies to state immunization registries for quite some time now. So I can't speak to the standards that the pharmacy systems have in place, but when they are coming into the state immunization registries, in many situations, the registry then is taking on the standardization of that address. So that as they're getting many different incoming sources, on Molly Murray, if I got my flu shot at CVS, but then I get my COVID vaccine at another place, that when the state IIS gets that information, they would be able to standardize it and be sure that it's all for the same Molly Murray. So again, I can't speak to the standards that the pharmacy systems may or may not use, but in that particular scenario, it's the state immunization registries that help provide that standardization once the data gets into their system.
I just want to add, that was awesome, Molly. I just want to add that we are actively working with the National Council for Prescription Drug Programs, and they're working closely with us on the technical work group as well to be able to understand sort of the feasibility of absorbing the specifications of their existing standards. So we hope eventually more of the pharmacy space will, of course, adopt it.
Oh, good. Excellent. That's great to hear. So Dan, let me ask you, with the importance of Project USA, so until that's actually delivered, what can organizations do now to standardize the addresses in their databases today? What's available right now?
Well, there's, I guess from the perspective of matching, really having some consistency in how how you filter out invalid records is kind of important. I mean, we see all the time that people are putting things into address information that really doesn't represent the patient's address at all. And so there's kind of, if I try to categorize like some of the biggest problems that we have with addresses, first of all, is it captured at all? So at least having some sort of metrics that are maintained, that indicate to what extent at different points of capture is the address, being captured at all, and then the other things we often see people are placing, all sorts of interesting text in the address information, like, see this other patient's record or some other garbage. None of these things tend to be problematic because, while our system, we have a large database of all the stuff that we've seen over 20 years of the crazy things people enter, other systems may not have that, and if you start to place non-address information into the address fields, then you're just asking for some trouble to happen at some point with some system that is relying upon that to do some sort of maybe rudimentary correlation of patient records. So just kind of very pragmatic, simple things is, are you capturing it at all? And if you're capturing it, is it really the address of the patient? Or is it something else that doesn't really represent the patient? I think that those are low-hanging fruits, that an organization can take immediately. And then just kind of understanding that having a level of data governance and monitoring is really pivotal, because if at some point you start to roll out these changes and you're trying to figure out how as an organization you're doing in terms of meeting those standards of populating the records, populating it in a way that is either deliverable or matchable. If you don't have anything in place that's kind of monitoring your progress, then it's kind of hard to know whether you've done anything effective or not. And a lot of the reason that we place a lot of emphasis on reporting within our application is to provide those sorts of metrics to people to say, okay, out of your patient population, how many of them have what appears to be valid addresses, So, but those are things people can do even without necessarily the MPI. They could do it in a different fashion, and just kind of gather those statistics.
And we've got a great question here along the lines of letting the perfect be the enemy of the good. So,
Yeah.
Could we issue standards for what we agree upon before we reach the perfect complete standards for areas we disagree on? Carmen, I'm just wondering if you could kind of answer why we have to go through this process.
Sure. So I'm certainly welcome, you're certainly welcome to review the draft specification. It's a messy draft, but we want to be as transparent as possible in our processes. And I'm not sure that any standard in existence is perfect. And it's not necessarily my goal. our goal is really the small incremental and meaningful changes that we've all, discussed today. And we want to be able to, there will be many, many iterations, just like any other standard moving forward. So we're not holding it close to us. We're not expecting perfection at any time. We would like to, as it goes through its own evolution, be able to measure its impact on the improvement of patient matching, just as the type of research that Pew has led in the past. And hopefully some other additional research will also inform future versions.
And I think it's hard to get to agreement, despite the fact we think there's a lot of agreement. It takes a while to get there industry-wide. So Molly, we've got a number of questions here about the National Patient Identifier. I wonder if you could just let folks know, what are the general I mean, you guys have done a lot of research on this. What are the general objections to it? And why don't we just do that?
Sure, great questions. So I think one piece is that there is still a ban on using federal funding to develop a national patient identifier. And there's been some movement in the past year. I think it was in 2019, a bill passed the House to remove that funding ban, but it did not pass the Senate. There's been some conversation about that again, though certainly the pandemic has changed prioritization. So I don't know the status of where that might be in terms of legislation, but that's one particular barrier. The other is that I think there are certainly some concerns about privacy and using a unique number associated with an individual and having the same kind of challenges that we might as if that were a social security number. I think the other thing is that there's no silver bullet, unfortunately, for patient matching. There's not, one single thing we can do. We'll get everyone to 100%. And Molly Murray will never be confused with the Molly Murray who lives, 3 blocks away from me. So while a unique patient identifier could improve the state of patient matching, it wouldn't solve everything. And so what we're looking to be able to do is make improvements in the data fields we've got, like address, and also continue to think about, creative ways that we might be able to enhance patient matching with federal assistance, since that ban does still exist.
Yeah, and historically, there's been a lot of privacy concern around unique patient identifiers. So I think that can't be understated. Okay, Dan, we've got a great question for you here about standardization and verification of addresses are critical foundations. What about address data enrichment with geocoding and reverse? Can you talk about that?
Yeah, no, absolutely. I mean, like I say, it is a kind of a separate area of beyond kind of the matching is can you add to the address kind of tags of information that is valuable, and certainly knowing the latitude, the longitude, the exact position of an address and whether it's a delivery point or not. These are certainly valid pieces of, not valid, these are certainly very useful pieces of information, from the perspective of, like I was describing earlier, if you're trying to make a referral for a patient and for example, what are the different facilities of care, and the exact location of the patient, then that's certainly very useful in sorting a result set and presenting it to the patient. Similar with analytics, if you want to get beyond just kind of doing high-level analytics on postal codes, but really drill down to maybe specific areas where there might be hotspots of either disease or some other kind of metric that you're dealing with. So absolutely, the data enrichment is very valuable. It's just that I think one of the goals with Project USA was not to make that a requirement, that you had to get to that point of being able to determine whether the address is a valid address within the U.S. and the exact rooftop that it indicated. But no doubt that doing that has a lot of benefit, and that really is the the next level. I'll just say briefly around the National Patient Identifier. We have a lot of experience actually working in England with our EMPI, despite the fact that England has had the NHS number since the 90s. That's not to say that it doesn't have value. It absolutely has value. They have a far smaller problem of record duplication and fragmentation than in the US. But I think the important thing to think about is if the US does, and we're proponents of it, if the US does move towards funding a national patient identifier, you shouldn't think of it as just like a number. You know, it's not going to be a number, just like the Social Security number is a number where, you know, if you drop it on the floor and somebody picks it up and says, oh, now I know everything I need to know about Dan. You know, in most likelihood, this kind of next generation patient identifier, national patient identifier, is going to be based on some pretty heavy duty cryptography and things going again back to the notion of decentralized identity and other work that has been done outside of the healthcare domain, really, but really something that applies to identity as a kind of across all industries. Absolutely, I think that at some point, you know, we're not going to be quibbling about, you know, how well is the address formatted or the phone or whatever. That I'm hoping that 10 years from now, we're not going to be talking about that.
We might be, Dan.
No, but we might be. Yeah.
No one knows.
And it's a super important for today. Absolutely, yeah.
Really important. So we've got just a couple minutes left. So I'd love to go around and just ask each of you to share some final words of wisdom or guidance for people who are, you know, heading on this journey of patient matching. For those of you in the audience, if you'd like to share in the chat box or comment box any thoughts on the webinar today, we always love your feedback. Hope the session today was helpful. Let us know. And why don't we start with you, Carmen? A couple of final thoughts for people to take away with them.
Sure, final thoughts. You are all welcome to become Project USA partners. I definitely want to keep everybody engaged and engage even more of your colleagues and friends. And finally, you know, every discussion around patient matching, you know, many times always comes back to data quality. And I cannot emphasize the importance of data quality quite enough. And standards in itself will improve data quality, but not alone. And so look at your entire ecosystem and supporting processes, because it definitely takes an entire system to improve that.
Great. Molly.
Absolutely second to all of that. And I think mine will be short and brief. Pew's favorite things about patient matching to come back to are ways to improve our more data and using standards with those data.
And Dan, final word to you.
Just to thank you, Jen, Molly, and Carmen, especially Carmen for you know, inviting us to being a member of Project USA. And yeah, I think these discussions are helpful, at least, you know, to raise awareness, and to the extent that the industry can work together to solve these problems. I think then the you know, organizations working in isolation doesn't work so great. So all again, and I guess that's it.
Thank you. All right. Thank you, Dan, Carmen, and Molly, for all of your expertise today. We appreciate it. And thank you, everybody, for joining us. Hope to see you next week when we talk about vaccine passports. If you have any comments for us on the session today, please put them in the chat box for us. We'd love to hear from you, and appreciate your time today. Everyone, have a wonderful afternoon and a wonderful holiday weekend.